Hello and welcome back to our exciting medical sciences lecture series on World Thrombosis Day. World Thrombosis Day aims to help raise awareness about blood clots in veins and how we can better understand the causes of this disease. With this in mind, we are delighted to host today's lecture in honor of this very important World Day titled Understanding Why Some People Get Blood Clots. Thank you very much for joining us. My name is Seita Diop. I am a current medical innovation enterprise student here at UCL, and I'll be your chair for today's event. Today's fascinating lecture will address the causes of blood clots and the strategies for prevention and treatment. So we want to keep these lectures as interactive as possible. So please make good use of Twitter and the Q&A function on the Zoom throughout to submit your questions for our speaker. The hashtag to use on Twitter is hashtag FMSLectures. So I'm delighted to now introduce our speaker. We have Dr. Keith Gomez. Dr. Gomez trained at St. Thomas's Hospital Medical School, University of London, and graduated in 1992. After studying hematology in the North London training programme, he joined the hemostasis research group at the Medical Research Council in London. Dr. Gomez's current post is consultant and associate professor in hemostasis in the Haemophilia Centre and Thrombosis Unit at the Royal Free Hospital in London. His main research interests include the genetic basis of inherited disorders of coagulation, the diagnosis and management of platelet disorders, and the clinical management of the rarer factor deficiencies. Thank you once again so much for joining us today. And now over to you, Dr. Gomez.
Seita, thank you very much for that very kind introduction. So yes, I'm going to talk to you today about why people get blood clots, and this slide gives you an overview of the areas that I'm going to cover. So first of all, I think we'll have a talk about the different types of blood clots that humans get and why they're different, which is to do with understanding the mechanisms really of blood clotting. And then the second part of the talk will really focus on venous thrombosis, because as you'll see, that's a really very different illness to arterial thrombosis. And then, of course, it's all about stopping and treating people, really stopping them getting thrombosis. And so we'll talk about some of the strategies we have for that. Now, at this stage, I think what we'll do is we'll start with a poll, because I think it's helpful to try and just work out what it is that we already know, or the audience already knows, about venous thrombosis. So hopefully there's a poll appearing on your screens now, and you can see that you've got basically the stem. What it's asking you is whether you think venous thrombosis is more common, causes more deaths than these four other conditions that are shown on this slide. So for each one, you can answer true if you think that venous thrombosis causes more deaths than, for example, kidney cancer, heart attacks, lymphoma, one of our commonest causes of blood cancer, or road traffic accidents. So for each one, answer true or false. And then as you can start answering now, start filling in the poll. And then we'll give that about 30 seconds or so. And then we'll see what people think, whether venous thrombosis is more or less of an important cause of death than these other conditions. And then I'll show you the answers, if you like, what actually the numbers are. And so this is just so these data. The data that I'll show you is basically taken from the Office of National Statistics, which publishes causes of mortality in the UK each year. Freely available. Anyone can look at them. You do have to understand mortality codes, if you like, but there's a key to help you with that. And then you can look up what the individual codes are. So click, as I say, true if you think that venous, for example, the first one is more common as a cause of death than kidney cancer, and then you've got heart attack, lymphoma, and road traffic accidents. And obviously, if you think that they're more common than venous thrombosis, then you click false. So I think we've probably been running that for long enough. Perhaps we could see what the results are. All right, so okay, so we can see that, okay, maybe people are thinking, obviously I'm talking about venous thrombosis, so clearly I'm not going to talk about it if it's not important. So, okay, you can see that about 3/4 of people think it causes more deaths than kidney cancer. A bit more, well, more people going for heart attacks there. Lymphoma, yeah, we think it causes more deaths than lymphoma. Or about a split on road traffic accidents. All right. Fine. So I'll close that, and I'll go back to let's go back to our slides, and so these are the actual figures. So as you can see, last year just over 5,000 people in the UK died as a direct result of venous thrombosis, and the other numbers in red are from the other 4 causes. And you can see that that's more common as a cause of death than anything except heart attacks. And that's about right. Heart attacks are very common. I mean, they're all important causes of death. We're obviously looking at these data. We're perhaps better than we think we are at preventing deaths on our roads. But what's interesting here is that it is still a very significant cause of death. And at the end, I'll show you how these figures compared to about 15 years ago or so, when venous thrombosis was much more common. But we can see that it's an important cause of death, and more common than some as a cause of death than some common cancers. So let's then go on to the different types of thrombosis. And when we think about thrombosis, we think about blood clots in the veins or the arteries. So this stylized diagram, if you like, shows you human circulation with veins in blue and arteries and the heart here in red. And on the right-hand side, you've got the commonest types, or the most important types, of arterial thrombosis, which are strokes or cerebrovascular accident, and then at the bottom there, heart attacks or myocardial infarctions. And on the left-hand side, you've got the venous thrombosis, deep vein thrombosis, and pulmonary embolisms. And these are very different types of blood clots. And to understand why that is, we need to first of all look at the blood vessels in which the clots occurred. So again, a bit of a stylized diagram. Blood flows from the right-hand side, I think, on your screen, over to the left-hand side, the venous side. So from the arteries to the veins. And the arteries are, the arterial side is a pumped circulation. So the heart is pumping blood around. It's high pressure, fast flow. The job being to deliver a steady supply of blood to the organs. On the other hand, on the left-hand side, the veins, they are a low-pressure, slow-flow system. So if you look at the cross-sections that you can see there of the blood vessels, you can see that arteries are really very muscular tubes designed to resist that really high pressure. And the muscle then forms a very, very thick layer. Whereas the veins on the left-hand side, you've got much, much thinner vessel walls. You don't need such strong muscles. And in fact, what's not shown in that diagram, which I'll show you later, is that the key difference is they contain valves. So whereas in the arteries, you've got blood flowing because of pressure from the pump. In the veins, you've got blood flowing more because of the pressure coming through, if you like, and then veins stopping the blood flowing back. It's a bit like anyone who's driven a boat down the Thames, for example, will know that you get locks that separate the river from one bit to the next. That's essentially what veins do. They stop the blood flowing back and allow it to flow onwards back to the lung. So let's now look at, this is going to be a little video, which I can't take any credit for. It comes from this group here in Spain who produced some lovely videos of blood clots and blood circulation. And when I press play, what you'll see is what happens when this blood vessel gets injured. So what you've got here, just to orientate you, is it's essentially the same as what you had on the previous slide. You've got the blood vessel wall here with smooth muscle, and then the lining in yellow. And then you've got the constituents of blood with platelets in green, red cells, and then white cells shown as well. So if I press play, what should happen is hopefully that's playing. Then you'll see that the bottom of this blood vessel is going to get injured. And as it gets injured, blood's escaping. And you can see that there are these white fibrous strands appearing, and the platelets are coming to the site of injury. And together, these white strands, which are fibrin, that's fibrin clot, and the platelets together, you can see they form a plug. And that plug stops blood escaping. And you can see that the blood is now flowing normally through the blood vessel wall again. Now, this is, of course, not the end process, because you've got a damaged blood vessel. What you then have is healing and then ultimately remodeling so that the blood vessel reforms again. But that's a really important physiological defense mechanism in all animals, because if we can't stop ourselves bleeding, then essentially we would exsanguinate. So this is an important normal physiological process. But if we go through to the next slide, then we can see what happens when it goes a bit wrong, if you like. So this is a video of arterial thrombosis. So you can see straight away that while it's once again a blood vessel, the blood vessel looks a bit different. Now what you've got is you've got a blood vessel where the wall here has got these two humps, these abnormalities, which is basically atherosclerosis, deposits of fatty tissue, cholesterol, things which have basically damaged the muscle wall. It's not functioning properly, and also it's blocking, it's starting to block. It's not blocking yet, but it's starting to compromise the lumen. It's starting to protrude into the lumen. So if I press play again, and this is arterial thrombosis, you can see that what happens is as the blood is flowing along, then it's now there's shear force onto this damaged atherosclerotic plaque. That breaks off, which is basically the same as the injury process I showed you on the previous slide. Now what's happening is you've got fibrin clot and platelets forming again, exactly the same clot that's forming, but it's forming inside the blood vessel wall, and that's the problem. So thrombosis is the clot forming, but instead of it forming in the vessel wall, which is normal, it's forming inside the vessel, in the lumen, and that blocks the circulation, which is clearly harmful. And now you've got no circulation going to the end organ that this blood vessel would be supplying, and that causes enormous problems. So that's where the problem arises. So you can see that you've got thrombosis is basically pathological blood clotting occurring in the wrong place. So this is arterial thrombosis. And if we look now, again, so on the right-hand side, you've got arterial thrombosis. So arterial thrombosis is primarily a disease of the blood vessel wall. It's the blood vessel that's abnormal. It's not the blood itself. And you can see again here a blood vessel, an artery on the right-hand side here with this plaque. Whereas if you look on the left-hand side, then you've got venous thrombosis. Now in venous thrombosis, the blood vessel itself is largely normal. The problem is in the blood. And what happens here? Now you can see valves here, right? As I said, you get valves in veins, which you don't get in arteries. What's happening here is that because of abnormalities in the blood itself, the blood is hypercoagulable or prothrombotic. It promotes fibrin clot formation. So whereas on the right-hand side, arterial thrombosis is primarily an abnormality of platelet-dependent clot formation. It's the platelets that are driving that process. And so we treat that by giving drugs which are anti-platelet. On the venous side, it's not so much to do with platelets, it's more to do with fibrin clot formation. And so we use a different type of medication, which we refer to as anticoagulation. Now, there is some overlap here. You can sometimes use these medications for the other indication, if you like. But I think this is a really important distinction because it helps us to understand why certain people get one clot or the other and why we use different treatment options. So let's focus a bit more on venous thrombosis now and the types of venous thrombosis we get. So as I mentioned, deep vein thrombosis, pulmonary embolism, and they're essentially the same disease process. So sorry if this slide is a bit small for you, but the blood clots essentially form in the deep veins, and nearly all venous thrombosis forms from deep vein thrombosis. And you can see the image here showing you pretty much what I was showing you on the previous slide. But what's happened here is that the thrombosis has now become big enough so that some of it is basically broken off. And when it breaks off, that's an embolism. An embolism is simply the thrombosis of the bit that's broken off, and it embolizes to the next place, if you like, where the circulation narrows again, and that's in the lungs. So we get pulmonary embolism forming as the broken off bit of clot flies up, if you like, or not flies up necessarily, but floats up into the lungs, lodges in the pulmonary circulation, and that is the biggest cause of death in venous thrombosis. Because if we block the pulmonary circulation, then we can't oxygenate the blood, and essentially we have a severe hypoxic injury, put strain on the heart, and if that's big enough, then unfortunately that can lead to death. So why do these things occur? So that's about understanding, if you like, the risk factors for thrombosis, whether it be venous or arterial. So I've shown you that on these two slides, and the left-hand side in blue are the risk factors for venous thrombosis, right-hand side in red for arterial thrombosis. These are not exhaustive. I've just put on here some important risk factors because I'm going to go on to discuss some of them a bit later. What's important to understand is that mostly what appears on the left-hand side does not appear on the right-hand side and vice versa. And that comes back to what I was saying, is that these are different types of thrombosis. There are different causes. So broadly speaking, if you've had a deep vein thrombosis, you are going forwards not necessarily at significantly higher risk of having a stroke or a heart attack. And the opposite is also true. If someone's had a recent heart attack or they're in hospital with a stroke, then they are at risk of venous thrombosis because they come under this category, other medical diseases. But otherwise, they're not particularly at higher risk of the other thrombosis. And that's because you can see the risk factors are quite different. Now, there are some risk factors that occur in both, and they're important: age and obesity. It's well recognized that age, or increasing age, really is a risk factor for many medical diseases. And it's perhaps not something we pay enough attention to, maybe because at the end of the day, we can't stop ourselves getting older. But I think it's important to understand what the effect of age is. And that's shown on this slide. So here we've got a simple graph showing you the IR incidence rate of venous thrombosis per 100,000 people in each age category. And essentially, as you get older, you can see that the incidence rate, i.e. the number of people getting blood clots, venous thrombosis, increases. But this graph shows you a few other things which are worthwhile noting. So young people are very unlikely to get venous thrombosis. But you'll notice that females, the black line, have a slightly higher rate of venous thrombosis than men when they're in their 20s and 30s. And that is largely due to the use of combined oral contraceptive and pregnancy, because as you saw on the previous slide, those are risk factors for venous thrombosis. And then as women stop using the pill, stop having babies, then you can see that at around about 50 years of age, the two lines intersect. After that, you've got the effects of the menopause. So women are going through hormonal changes, but there's still a little bit of a difference there. But then ultimately, as you get older, then the rates are a bit different in men and women. But I think that really the important take-home message from this slide is that the risks in someone who's in their 70s are much, much higher than the risk of thrombosis in someone. So a fit and well 70-year-old has a much higher risk of thrombosis than a fit and well 30 or 40-year-old. That's the key message from this slide. So when we think about risk, I think it's important to think about absolute risk, which to me is, and I've shown you what that means here on this slide. So absolute risk, which is the second row, is to me the actual chance of the person in front of me in clinic getting a venous thrombosis. And that's different to relative risk, which is, if you like, the increase in risk due to a particular factor. So if we look at the bottom then, this table, we can see, and these are sort of figures that you'll easily pick up from, the Sunday Times or something. And there's lots of articles about how the combined pill might increase the risk of thrombosis. And if you look at these numbers, you can look and go, well, cancer increases the risk 4 times, the same as combined oral contraceptive. That sounds bad. I mean, it's not good, but that sounds as if it's a very similar risk, if you like. But if we think about absolute risk, how do we do that? So first of all, let's think where these risks apply, if you like. So cancer is, again, unfortunately, predominantly a disease as people get older. So if we take, I don't know what the average age of someone with cancer is, but I've taken 70 here as an arbitrary figure. You can see from the previous slide that the chances of someone who's 70 getting a blood clot is about 1 in 540 each year. Whereas the chance of a fit and well person, a woman who's 20 years old, much, much less, 1 in 10,000. So if we put this 4-fold risk onto those figures, we can see that the absolute risk becomes, for a 70-year-old person with cancer, their risk of thrombosis becomes about, well, just over 1 in 100, which is significant because, of course, we have hundreds of people coming along with cancer. We need to look at those individuals and see which ones are going to get a thrombosis and do something about that. Whereas if we look at the combined oral contraceptive users, we can see that even though that does increase the risk a bit, you're still only looking at a risk of 1 per 2,500 users. So really, in terms of absolute risk, it's a really, really low risk, which is why we don't go around stopping the pill. And of course, the pill has significant advantages in terms of stopping pregnancies, for example. So it's an important way, I think, of looking at things. And so I don't tend to say to someone, you can't use the combined oral contraceptive. Rather, I think of it in terms of assessing their absolute risk. And so if you take this person who's 20 years old, and then they're now 15 years older, and perhaps they put on some weight, perhaps they've started smoking, now their risk changes because their baseline risk due to those other things, getting older, is a bit higher. So now the risk becomes a bit more significant. We're now looking at 1 in a few hundred. They might still find the pill's a good thing to use, but on the other hand, I think we have to now think quite strongly, and often that would be why we would stop using the pill in those people. So you can see that while the second column, relative risk, does not change, the absolute risk in the far right-hand side changes depending on the circumstances. And I think that's really what we should be paying attention to. Okay, so as Sata said, today is World Thrombosis Day, and I'll tell you a little bit more about that. But first of all, some facts about venous thrombosis. So as I showed you in the poll, it's a relatively common cause of death in the UK. And what's important here is that a lot of those deaths are associated with being in hospital. And what that means is that that's often a point at which we can intervene. So these are often preventable deaths. And you can see here that it's one of the leading causes of preventable death, largely because when things occur in hospital, we can predict a bit more when they're going to happen and do something about them. And so World Thrombosis Day was started about 8 years ago now. The first one was in 2014. And it was essentially a day that was born from experts and other people interested in thrombosis coming together and saying, we need to raise awareness of this. We need to make it an important topic on a global stage. And so across the world, there's talks like this and other events going on to raise awareness of venous thrombosis so that we can carry on working trying to reduce this number of people dying from venous thrombosis. So often I get asked about genetics because people, and it's one of my interests as well, how much of this to do with the fact that there's an inheritable component, because we often hear about blood clots occurring in someone's mother or father or aunt or uncle, and therefore it's attributed to genetics. And indeed, thrombophilia, and by thrombophilia we mean a heritable cause of venous thrombosis. Yeah, that does cause thrombosis. And if you do some studies where you look at people's genes and look at their those are called genome-wide association studies, and look at how many of those get thrombosis. The thrombosis risk, there is a heritable component, that's for sure. However, when we then try and look at individual genes and work out which genes it is that cause thrombosis, then rather disappointingly, that only accounts for about 5% of cases. So why is that? Well, it's partly because the risk of thrombosis related to it from a genetic perspective, there's lots of different genes that can contribute to thrombosis. So this is a fairly technical slide, so I'm sorry about that. But what it shows you is a set of genes, or some genes, the gene names on the left-hand side. These are various proteins involved in blood clotting. And some of these are abnormalities that might be in common knowledge, like this one, factor V Leiden, and some of you will hopefully have heard of that. It's a very common abnormality in the population, 3 to 8% of the population. As you can see, a relatively modest increase in risk of venous thrombosis. And to put that into context, what I mean by modest is that it occurs in this number of the general population. 90% of these individuals will go through their whole life without ever getting any kind of thrombosis whatsoever. So it's a weak risk factor. And then you've got other genetic changes which are less common. So for example, these changes in protein S. And as you would expect, things which are less common have a higher risk actually. So risk is inversely related to how common something is. And that makes sense from a nature selection point of view. And partly the reason I put this up is because within medicine, there's various things that you can test for. And there are some things that were thought of as as predicting the risk of venous thrombosis, and they're shown at the bottom here, abnormalities in these two genes. But as we went on to do these genome-wide association studies, we found that these were actually very, very common, found in even half of the normal population. Clearly, half of people don't keel over with a blood clot. And so these studies have shown that actually they're of no importance. So the importance of understanding genetics is not just to help us work out which genetic changes are important, but it also tells us which ones aren't, and therefore which ones we don't need to worry about, or we can reassure people that, look, you've got this change, but it's not significant. It's also led us to think that probably what we need to do is rethink the way we consider genetic disease in some of these cases. So I've used a term here, monogenic disease, and what I mean by that is a traditional way of thinking about genetic disease where you have a genetic change, it causes a disease, and basically if you have that genetic change, you're going to get the disease. So in this case, if we think of the disease as thrombosis, then what we were looking for is a genetic change in a thrombosis gene, and then whoever has that change gets the thrombosis. But phenotype, i.e. the getting of the thrombosis, is actually dependent on then three different components. In grey, there's the genetic change that I've just referred to. In blue, there's changes in other genes, because as I've just shown you on the previous slide, it's often multiple genes coming together. And in orange, there's other things. So that person then perhaps becoming obese or smoking or getting some other illness that makes them more likely to get thrombosis. So you can think of it with three different components. I've started off drawing them with an equal contribution to the risk of thrombosis. But And so if we think about a thrombotic condition, so protein C deficiency, rare but a well-known cause of thrombosis. So then the grey part of the pie, if you like, becomes a variant in protein C, other genes, and then, as I said, things like obesity can also contribute to getting a thrombosis. So severe protein C deficiency, where an individual has a very, very low level of protein C, they've got quite a severe genetic abnormality. You can see that what causes thrombosis is almost entirely due to that variant, i.e. everyone with that abnormality will get a thrombosis. Fortunately, that's extremely rare. And so the other things going on, they don't make much of a difference. It's not much to do with age or anything else. And here, mostly everyone with that abnormality will get a thrombosis perhaps when they're before they're 20 years of age, often as a child. But if you take a milder version, and the right-hand side is much, much more common, people with mild protein C deficiency, we can see now that while the genetic change is still important, you can see that the other parts of the pie are now bigger. They play a bigger role in whether or not that person gets thrombosis. And so we can do things about that. We can change their environment. We can hopefully stop them smoking, for example, or doing something else to reduce their risk. And most importantly, if we treat them with anticoagulation, then we move them from the left-hand side to the right-hand side and make them milder. So you can see how understanding genetic disease, understanding the interplay between different genes, helps us to work out the risk in an individual. And I mentioned their treatment, anticoagulation. I'm just going to show you one slide here, and hopefully this one slide is going to be enough to show you how useful this treatment is. So this is a really old slide. You can see, 1999. So even in the last century, using one of our very old, tried and tested, long-standing anticoagulant drugs, warfarin. And basically, these are individuals who've had a venous thrombosis. And you can see that, and then what we're doing is a few months after that, we're looking to see how many of them get another venous thrombosis. And the top part of the graph shows you that if you give these people a sugar pill, basically, after a year, nearly about a quarter of them will have had another thrombosis. But if you give them warfarin, if you anticoagulate them, then that number goes down to nearly zero. In fact, we know it's about 1 or 2%. Tremendously effective. We've taken that risk down from 25% to 1 to 2%. So it's an enormously useful intervention. It does carry a small risk of bleeding, but the risk of bleeding is about 5% maybe. Now that's non-major bleeding. So, that's clearly a significant advantage. 25% reduction in thrombosis versus a 5% of risk of bleeding. So a very, very good treatment. Okay, so I'm going to come towards the end of the talking part of this now in a moment, but I'm going to talk about prevention of venous thrombosis and what we're doing in the UK. So this all started really about 15, 16 years, 17 years ago, actually, 2004, with a House of Commons Health Committee. And you can see you can look this up it's freely available on the House of Commons Publications website. They produced a report entitled The Prevention of Venous Thrombosis in Hospitalized Patients. And some of these figures I've already shown you, 10% of all hospital deaths. Look at this number. It's much, much higher than the number I showed you in the poll, about 6 times higher. So you can see that was the number. That was the number of people dying in the UK as a result of venous thrombosis. It may be that it's a little bit higher than I've given you, partly because I think they included any death where venous thrombosis made a contribution, as opposed to it being the main cause. But nevertheless, it's undoubtedly much higher. So we've already done a fantastically good job in reducing that number. In 2004, this was the annual cost to the NHS, 640 million. And to put that into context, that's about 1% of the NHS budget at that time. So 1% cost attributed to just one disease. So it's a significant chunk. And you can see the reasons here that the committee members decided that we were having this problem: lack of awareness, concerns over bleeding. Well, I could have shown you on the previous slide the bleeding risk, and it's relatively low. Inconsistent guidance, that was something we had to address. And very, very important at the bottom, lack of funding. I'm sure you all know that's often the thing in the NHS, lack of funding to stop us doing things. So as a result of this, we had various initiatives. We had a national VTE prevention program in 2010. We had, and what that said is that each hospital should have a thrombosis committee, and that when patients were admitted to hospital, they should be risk assessed. Where there should be specialist nurses to look into why people were getting thrombosis in hospital, and there were financial penalties for hospitals that didn't comply with this, that didn't do these things. And on the left-hand side, you've got one of our guidelines. This is the latest NICE guidelines. The first of these was in 2007. Basically, you can see that it's basically the guideline that we use to help us to treat and prevent venous thrombosis. And this is the way in which we assess risks in the UK. Now, this is probably a bit too small for you to read here, but there's 2 charts here. And the idea is that it's simply a kind of tick box, something quickly that a doctor can do when you come into hospital. The chart on the left-hand side is for pretty much all patients coming to hospital. The one on the right-hand side with the slightly more colourful boxes is specifically for pregnant women coming into the labour ward. And essentially, in the top part, there were these thrombosis risk components, which are basically the things that appeared on the risk factor screen I showed you. And if you tick one of these boxes, then it means that person should get thrombosis, unless you tick one of the boxes at the bottom, which shows that they're at increased risk of bleeding, in which case you then need to have a think about it and decide whether the risks outweigh the benefits. This is the paper form that was produced about 10 years ago. Now, a lot of this is computerized. So someone comes in, it appears on the health charts computer, filled in, and then it often automatically will lead to a prescription. And so that makes life very easy for doing this. I think that this is coming towards the end of the talk now. So the last slide with some data on it. So a report of the effects, if you like, of the VTE prevention program. This was last year. And as I showed you already, the number of deaths has come down significantly, a 21% reduction in post-discharge venous thrombosis deaths between 2007 and 2018. So that's a success by any measure. And while that's good, there's still some work to be done, because what this report also showed is that nearly a third of hospitals are still not quite meeting the 95% target of risk assessing everyone. And there's lots of problems with staffing in various parts of the NHS. But this is also an area we know we don't have enough nurses. There are various reasons why that is, but 30% of hospitals still don't have a dedicated nurse for VTE prevention. So this is my last slide. And these are basically the take-home messages that I hope I've shown you, that venous thromboembolism is a leading cause of preventable death. We can do something about this. We've got anticoagulation, which is safe, effective, and cheap. And if we do put funding and resources into place, like we did with the VTE prevention program, they can work. We can do something about it and reduce the impact of these diseases. So I'm going to stop there and happy to take any questions. I think you might be on mute, Sata.
I am indeed in mute, classic. No, I was just saying thank you so much for that. That was really fascinating. And yeah, we have had a couple of questions in our Q&A, so we can go over to that now. The first one, well, the only question we have for now. So let me start by saying, actually, if we can encourage you guys to ask any questions that you might have from the lecture, send them through to our Q&A. We'll be more than happy to answer these. We'll start off with the first one from Mim, who's asked, has personalized medicine, gene therapy, been utilized to treat venous thrombosis? And has there been any research progress in this area of medicine?
Okay, so a really good question. And obviously gene therapy is something which I think there's a lot of excitement about. So gene therapy works well in areas where you've got a monogenic disease. That's quite unusual in thrombosis. And where, if you like, a small change, i.e. just changing that gene, will effectively obliterate the phenotype, stop them getting whatever the disease is. That, unfortunately, as I've shown you, is not true of venous thrombosis. So the answer to your question is, while it is theoretically possible, it hasn't been tried. And the reason it hasn't been tried is because it probably wouldn't work. Even let's say you took someone with protein C deficiency, even if you were able to change that gene, the other factors that interplay into causing thrombosis would still be there. And those are, if you like, the blue and the orange bits of the chart I showed you. So we wouldn't be able to confidently say to that person, we've done gene therapy. It's a risky thing, gene therapy. It carries some really quite high risks. So it's got to be worthwhile. And for it to be worthwhile, we then have to be able to say, look, we effectively cured you, and we can't really say that with venous thrombosis. So no, I don't think gene therapy hasn't been tried. I think as things stand at the moment, unless it becomes a whole level safer and easier and cheaper, I don't think it's going to be used here in this condition.
Like you said, I like that. Maybe in the future we'll see where gene therapy can take us. Okay, so the next question is, for people on long-term high dosage of warfarin, do you advise any practices or implementations they can do in the built environment in their home and beyond to avoid bruising and bumps?
That's another great question. And look, perhaps I'm focusing on venous thrombosis, I rather underplayed the bleeding side of things. Bleeding is an important issue as well. And especially perhaps in women of reproductive age, if we anticoagulate young ladies, fortunately we don't have to do that often, but they're going to get heavier periods, for example, and that's going to cause a significant issue. So yes, that's an important part. I think partly it's important to reassure people that while bruising and bleeding from minor cuts does occur, it's very rare to get more serious bleeding than that. So it's not a thing to be worried about. In terms of preventing it, I think, that's probably a better question for someone who's on warfarin than me, I think. But I think what I hear from my patients is that they get used to being on the medication. Obviously, we check their INR very frequently and make sure that their warfarin is at the correct dose. I think it is a little bit about lifestyle changes. Some people have had to give up playing rugby, for example, or high contact sports where they would bleed. Yeah, I think they would otherwise bruise a lot. So it's about kind of changes like that, maybe lifestyle changes. A lot of it is just getting used to being on and being on the warfarin and knowing what it is that causes bruising, I think, and then avoiding those things. So yes, it is an important area.
Thank you for that answer. Our next question is from Jemima, and she would like to know, what are the ways in which the NHS are trying to raise awareness about venous thrombosis?
So Thrombosis Day, World Thrombosis Day is a big part of it. We have, so I know that there's that there's some meetings next week, and there's various other hospitals around the UK, colleagues of mine who are doing talks like this, talking to patients and in other groups. So that's one. Within the NHS, amongst hospitals, there are some initiatives. So I didn't go into the full details of the VT prevention program, but I'll tell you about one of them. For example, there was an introduction of what are known as VTE exemplar centres. And what those are is specialist thrombosis units with high levels of expertise in dealing with thrombosis. And the idea is that these centres, if you like, hone best practices and then share those best practices with other hospitals. So if you like, centres for learning. So I think through these sorts of initiatives, both inside the NHS and outside, generating awareness, then that's how we're getting the message out there. Thrombosis UK, which is the UK's leading charity, is a patient-led organisation. And a lot of it is, I think, getting the message out to lay people, and that's really important as well.
I really like to hear that, kind of the sharing between communities, sharing the learning and making sure we can all benefit from that. Thank you. Okay, so the next one is actually quite an interesting question. How expensive is it to screen for these genetic defects on admission during routine blood tests to reduce the amount of hospital-related deaths?
So that's been looked at because in some respects, it's not that expensive. And the more screening you do, the cheaper it becomes. And there have been various ways in which the screening can be done on not through kind of complex genetic testing, but through doing it on just a simple blood test, basically. But and this is the problem, it's to do with ultimately those tests are really useful if they accurately predict which individuals are going to get thrombosis. And the fact of the matter is they don't, for the reasons that I showed you. That unfortunately, what actually results in an individual getting thrombosis, that's only a small component of their ultimate reason why they get thrombosis. So you can do all this screening, and then you might go, okay, there's a group of individuals who tick, say, 5 of those boxes. That contributes to a small percentage of their risk. The rest of it is due to something else. So it doesn't ultimately change management. So thrombophilia screening, which was done on a really quite an enormous scale 10 or 15 years ago, as we started to understand, or as we started to know about these diseases and we learned how to test, we started doing thrombophilia screening a lot. What we then found is it didn't make a lot of difference to outcome. It didn't change who we could give anticoagulation to, and it didn't really, unless you have something like severe protein C deficiency, it doesn't really change the outcome. And to be clear, those families are relatively easy to pick up because they're rare, and what you see is a family history of blood clots occurring in young people from about the age of about 15 onwards. Very, very different to what we see elsewhere. So that's really where that's where we use thrombophilia screening now. If you've got young people, definitely, mostly at about 20 or so, 20, 30 maybe, or younger, definitely below 40, who developed a blood clot without there being a provoking factor like surgery or pregnancy, that's where we use thrombophilia screening.
Thank you. Someone would like to know, does it matter if they forget to take their anticoagulant?
A good question. And well, anticoagulation is about reversing long-term risk. Okay, so it's not about short-term risk. It's not that if you stop taking it, your risk suddenly jumps on that day. So while it's always good to not forget, and we wouldn't encourage people to do that, no, I don't think you need to panic that suddenly your risk has gone up. And to give you an example of that, if someone needs to have surgery or some kind of a procedure where they might bleed, then usually we would stop the anticoagulation, depending on which one you're on, for 1, 2, 3, 4, 5 days, something like that beforehand, and then restart it. And when we do that, the number of people, a very, very, very tiny number of people get a blood clot when we do that, but it's very, very small. And that shows you that it's mostly safe to stop it for a few days. And so missing it for 1 or 2 days isn't a problem. It's all about taking a medication which reduces someone's risk over a 2-3 year period. That's what it's about. If you don't take it, and you don't take it for months at a time, then over a 2 or 3 period, then your risk, as I showed you, is 25%. But if you take it and take it reasonably regularly, then it becomes 1%.
Thank you for that. I'm sure whoever asked will be relieved to know that answer. So we have another question. I've heard you mention a couple of times how pregnancy is a risk factor sometimes for VTE. Do you know what the reason is behind it, and how are pregnant women more prone to developing thrombosis?
So it's probably partly a physiological defense mechanism, because in the animal world in general, pregnancy is a state. I mean, it's a high risk physiological event for a female animal. And the reason for that is that the act of giving birth is inevitably associated with bleeding. And if you go back through history before there was advanced medicine, then, and in fact, sadly, even now, worldwide, a leading cause of maternal mortality is still bleeding at childbirth, at delivery. And in fact, there's separate initiatives that we need to try and do something about that. That's a big issue. So physiologically, you're more likely to bleed. How does nature protect women? Well, one of the ways it protects them is by enhancing blood coagulation. So if you go and measure blood clotting parameters, if you like, tests of the blood clotting potential, they're much, much higher in pregnant women. And that's good, because that's the way in which we stop pregnant women bleeding. That's how nature stops people bleeding when they deliver. Unfortunately, the drawback of that is that you then have to accept some increased risk of thrombosis. So that, in a nutshell, is the reason.
It's a double-edged sword, as
bit,
many things.
I think in terms of nature and evolution, there's no doubt that we want to stop people bleeding.
Absolutely. Thank you for that. Okay, so our next question is about athletes, and why do so many young people and fit athletes die of cardiac arrest? Is there a screening program for these people, and is it even related to deep brain VTE?
So it's not related. So that's what I wasn't talking about particularly. It's not hugely my area of expertise, to be honest, because it's to do with cardiac changes. The answer, I mean, but it's something which I think when it occurs, it's obviously devastating, and it's obviously, well, there have been a few very high profile cases, footballers, for example, as I'm sure many people will be aware of. And so that puts it very high in the, in I guess, the public awareness, if you like. As far as I'm aware, as I said, it's not particularly my area of expertise. As far as I'm aware, I think there are screening programs sometimes. I think that particularly high-level athletes now go, well, they all go through quite extensive health screening for sure. But I think cardiac monitoring is now part of that. And the reason I think that is that I'm aware of some cases where people have unfortunately been told that they can't pursue football as a career because of some cardiac abnormality. So I think the answer to that is there is some screening. I don't know enough about it, I'm afraid, to be able to answer whether that's able to detect all cases or not. I think I expect it won't be able to, because in reality, when you've got what are rare conditions that occur in people who don't have any external manifestation of it, they don't have any symptoms, you can't detect it through any other, it's unfortunately a very sudden event, then it's quite difficult to develop a screening test that will, with high degree of certainty, go, right, these are the people who've got it and can't play football, for example, and these are the people who can. And clearly, you've got to get that answer right, because if you give someone the wrong advice, then that could be bad on a number of counts.
Thank you. We've got a question from David. They'd like to know, is there good data on warfarin versus DOACs? I'm unfamiliar with that one. Perhaps you'd like to tell us what that means, after a person has had 2 DVTs.
Yeah, so DOAC, direct oral anticoagulants, that's what that means. And I showed you the data on warfarin deliberately because I wanted to show you an old slide to show you that we've known about these treatments for 20, 30 years. But that's a very, very good question, because the problem with warfarin is you have to monitor it. You have to have blood tests periodically to check that your warfarin is at the correct level. That's a bit of a nuisance sometimes. Well, not sometimes, probably all the time. And so in the last 10, 15, probably about 15 years now, maybe 20 years now, we developed what were originally called new oral anticoagulants, or NOACs, but because they have been around now for about 15 years, they're now more commonly called DOACs, direct oral anticoagulants. And the big difference between these drugs and warfarin is that warfarin works by a mechanism involving vitamin K. So it's what we call an indirect anticoagulant. And because it's an indirect anticoagulant, the effect can be prone to interference from drugs, what you eat, sometimes what you do. And so that's why we have to monitor it. Direct oral anticoagulants don't work that way. They're very specific molecules that target a specific part of blood clotting. In fact, one particular clotting factor. And that's great because it means that they don't have these sort of off-target effects. They're not prone to interference, by and large, from other medications. And so by and large, they don't need to be monitored. And so they're a huge advance. And I think the actual question was, have they been compared? Is that right? Yeah.
Yes, if they've been compared, specifically for someone who's had 2 deep vein thromboses.
Yes, the answer to that is yes, they have. They've mostly been compared in people who've just had 1 venous thrombosis. So there have been huge studies of people having a blood clot and then going on to warfarin, going on to a DOAC, and essentially what all of those have shown that in general, for most people, DOACs work just as well as warfarin. Okay. Now, obviously, those are in clinical trials. There's always going to be individual cases where warfarin might be better for specific reasons, and you know that's an individual case. But the specific example of someone who's had 2 blood clots, that's a rarer situation. There's certainly been two of the big studies of DOACs have looked at recurrent thrombosis, and so the answer to the question is yes, it's been compared. And yes, those drugs, the DOACs, are as good as warfarin in that setting, in those patients. Also, what those studies have shown is that for many people, you can use a reduced dose of DOAC. So you can use, you often need to use, if you like, an acute treatment dose at the beginning for the first 6 months, and then often it's feasible to reduce the dose, because you're now past the acute stage. The amount of anticoagulation you need is effectively a bit less. You can go to a lower dose, which of course then means that your bleeding risk is a bit less. So yes is the answer.
Thank you very much. Our next one, what are the side effects if anticoagulants are given for anyone experiencing heavy periods?
So we mentioned that a little bit earlier on the warfarin thing. So about 30% of women of childbearing age, i.e. women who are having periods, when they're started on warfarin, their periods become heavier enough that we need to do something about it, whether we be giving them iron medication or something else. And one really important point to make, which I think is something we need to get this message out, is that we know that the combined oral contraceptive pill slightly, very slightly, increases the risk of thrombosis. So often what happens is if a young lady is on the oral contraceptive pill, they get the thrombosis, often what happens is the pill is stopped. That is the wrong thing to do, because then what happens is you're taking away the thing that stops them getting heavy periods, and we're giving them a drug that makes them have heavy periods. Not a good option. The fact is that putting someone on blood thinning medication protects them against thrombosis, whether they are on the pill or not. So it counteracts that effect. So it's perfectly safe, and we've known this for well over a decade, perfectly safe to have a thrombosis and be on the pill while you're having your blood thinning medicine, i.e. have both at the same time. So a big part of the answer to that question is I encourage people to remain on the pill, particularly if they were on it because of heavy periods, which is often a good reason for it. And if they're not on it, then that might be something we can start doing. If it's someone who needs to be on the medication long term, say they're on a direct oral anticoagulant, DOAC, then that's where that dose reduction after 6 months becomes really useful, because you reduce the dose, get less bleeding. So yeah, that's how we deal with it.
Thank you. We have time for a couple more questions. So I'm going to go ahead and ask, are there any common misconceptions about venous or arterial thrombosis? And if so, what are they?
Well, I think the first one, which is why I spent a bit of time on that at the beginning, is thinking that they're the same thing. And lots of times when I ask people about their history of thrombosis, they say, oh yes, my father had a stroke, or my mother had a heart attack or something. clearly those are important conditions, but they are unrelated. Okay, so you don't need to worry that puts, broadly speaking, that puts someone at a greater risk. And equally, people then worry that venous thrombosis puts you at a greater risk of having a stroke. And the answer is that there are other more important reasons, which I showed you on that slide, as to why people get those conditions. So I think that's a very common misconception. I think the other common misconception, which perhaps is also amongst healthcare professionals, is that the treatments that work for one work well for the other. And that's also not true. And so broadly speaking, antiplatelet medications like aspirin work better for heart attacks and stroke, and less well for venous thrombosis. And so so aspirin isn't really, I mean, it does help a little bit, but it's not really a very good drug for venous thrombosis, for preventing or treating it. You can use anticoagulation in specific circumstances for people who've had stroke, but only very specific circumstances. And so I think those are the two big areas. They're different, and the treatments are different.
Thank you. We have another one that asks, are there any preventions taken with cancer patients so they're less likely to develop VTE?
That's something that there's been a lot of work on in the last year or two, and I'm involved in a group with my cancer colleagues writing some guidelines about that. So now what should happen is that anyone with cancer their risk is assessed. Now, mostly the risk is to do with when those patients with cancer have surgery for their cancer, or if they have to come into hospital because they're unwell or they need chemotherapy, i.e. they're acutely ill. And in those cases, most patients with cancer will need some form of anticoagulation preventative medication, okay? However, we're now really good at doing cancer treatments in what we call ambulatory cancer treatment, which is where patients come to the oncology day unit, and mostly they're outpatients. Do we need to provide thromboprophylaxis for those? That's a slightly more nuanced answer. It depends upon the type of cancer they have and essentially what chemotherapy they're giving. It depends upon their other risk factors. And the answer is that a small number of them do need thromboprophylaxis. Fortunately, it's only a small number. There are some specific cancers, pancreatic cancer, for example, myeloma. These are conditions where we would do that. But I think it's very much on a specific per cancer basis. And the good news is that now hematologists, oncologists are becoming aware of those situations. They have tools to help them, like that risk assessment I showed you, to decide which patients need it. And I think that's going to be an important step forwards to reducing thrombosis in those patients.
Brilliant. I think this will be our last one. We've got a question asking, is it possible for someone to have thrombosis without any symptoms?
Yes. So a lot of the older studies of how effective blood thinning medication was, we took patients who were having surgery, for example, and then we scanned everyone to see whether or not giving them blood thinning medication would work. And what we found is that some of them would have a blood clot. Now, of the people that we found a blood clot on the scan, some of those people would go, oh yes, my leg's painful or swollen. And others would go, no, my leg's totally fine. And so what that showed you was that there was a group of people who were asymptomatic. What then became clear is that the group that were asymptomatic seemed to do quite well by themselves, i.e. without us doing anything to them. And so the answer to the question is yes, you can have blood clots without having any symptoms, but the clinical relevance of that seems to be very little. And so actually, so lots of people wonder about doing scans, for example, like you've had a blood clot, should I have lots of scans afterwards to check that my blood clot has gone away? We used to do that. It didn't make any difference to the outcome. And in fact, now what we know is that the most important thing really is someone's symptoms. If their leg's getting better, it's not swollen, it's not painful, or mostly not, and they can do what they need to do, then by and large, that tells you that their thrombosis has got better. So the answer is yes, you can have asymptomatic blood clots, but what's important is that they're largely not clinically important.
That's good to know. Okay, so we are very sadly out of time and we'll need to leave it there. But if you could leave us, all of you watching at home today, if you could leave us with your feedback about today's session by filling out our survey, which will be sent out to you following today's event. It would be greatly appreciated. It helps us improve for our next events. And thank you again for all your comments and questions. And finally, thank you, Dr. Gomez, for an excellent lecture, and have a great evening, everybody. Goodbye.
Thanks very much. Bye then.